Hello, my name is Dr. Daniel Weiss, and for the past 16 years, I've been a practicing cardiologist and electrophysiologist in the U.S. About 7 years ago, I started working with an exciting, new ECG-based measurement called PD2i that can accurately identify patients at elevated risk of sudden cardiac death. This method has now been applied successfully to real-time ECG analysis and trauma triage to help identify which patients need an immediate life-saving intervention and which do not. In the U.S. alone, there are approximately 30 million trauma visits to the ER, with 150,000 deaths annually, and trauma visits account for more than 25% of all ER visits. Trauma costs close to $500 billion in medical care and lost wages and productivity. Trauma care is particularly crucial in the first hour, the golden hour. Critical questions regarding transport and resource use must be answered, often in a time frame of only minutes. Accordingly, there is an intense need for a fast, accurate, real-time method of trauma triage, which traditionally has focused on standard vital signs, which can often have poor sensitivity and specificity. The problem is especially severe in young, healthy victims with good compensatory mechanisms, whose defense mechanisms tend to compensate very well for blood loss and mask the degree of injury until it's too late. As we continue to develop therapeutic improvements in trauma medicine, we also need to give doctors better objective data about when to use these capabilities. According to the U.S. Army Institute for Surgical Research, costly errors of over and under resuscitation and over and under triage could be avoided by better diagnostics, as has been well documented in the medical literature, such as in the Journal of Trauma. With under triage, a provider fails to detect that a patient is critically injured in a timely fashion. In worldwide studies, the causes of preventable trauma death included failure to diagnose approximately 10 to 15% of the time, which results in both delays of operations and in management errors. With over triage, a provider diagnoses too many patients as critically ill. This occurs in 50% of patients in urban U.S. trauma centers. In a resource-scarce environment, such as a mass casualty event or on the battlefield, over-triage causes an increase in the mortality of those truly critically wounded by using up scarce resources. In addition, on the battlefield, over-triaging patients can lead to placing rescue and evacuation personnel under life-threatening enemy fire unnecessarily. There is also a need for a new metric or vital sign that will track a patient's progress after the triage decision has been made, as continuing care is given. But now, there is science that can make a difference. It starts with a new vital sign, PD2i, the point correlation dimension, which has been studied in collaboration with the U.S. Army and shows great promise of being an invaluable tool in the triage and continuing care of both battlefield and civilian trauma. The physiologic response to trauma is controlled by the autonomic nervous system. Therefore, a parameter that assesses the autonomic nervous system should provide useful information regarding the body's status after trauma. That parameter is PD2i. PD2i is a form of heart rate variability, and for trauma requires just 200 heartbeats of a single lead of ECG, only about 1.5 to 2 minutes in a tachycardic trauma patient, and is very tolerant of noise and ectopy. In a presentation at the 2009 American Heart Association's Resuscitation Science meeting, the U.S. Army researcher stated that PD2i was the best metric for real-world ECG data precisely because it is so tolerant of noise and ectopy. PD2i gauges the level of cooperativity in the sympathetic and parasympathetic arms of the autonomic nervous system. More independence signals health. Disease or injury are implied by more cooperativity, the result of the body being forced to increase the coordination of the autonomic nervous system to maintain homeostasis. PD2i has been evaluated by the U.S. Army as an indicator of the need for a life-saving intervention in both military and civilian trauma triage. In separate clinical studies of both battlefield and civilian trauma, comprising almost 500 patients, a minimum PD2i score below 1 was consistently found to be highly predictive of the need for a life-saving intervention, with a sensitivity of nearly 100% and a specificity of approximately 60%. In one study, only 30% of patients who died were recognized by medics and doctors as needing a life-saving intervention. The other 70% died without any immediate medical care even attempted. PD2i correctly identified all the patients who died. PD2i can detect even mild hypovolemia, such as that caused by mild blood loss. This means that PD2i can be used to help detect hemorrhage early on in a patient who might otherwise appear stable. PD2i is also useful in emergency rooms for non-trauma patients. In a study of over 900 patients presenting to the ER with chest pain, PD2i detected those patients at risk of cardiac arrest within the next 12 months with a sensitivity of 96%, a specificity of 85%, and a relative risk of 24%, making it an invaluable tool for the ER physician. PD2i can track a patient's progress through emergency care. A study by the U.S. Institute for Surgical Research showed that PD2i both reacts acutely to traumatic injury and changes in parallel with clinical improvement or worsening, thus providing an invaluable tool for assessing the clinical progress of trauma patients. PD2i not only mirrors clinical status, it changes before the acute deterioration occurs. In this video, we see that in the minutes leading up to a cardiac arrest, the ECG is unremarkable until the last second, but PD2i fell into the danger zone, as indicated by the red light, well beforehand. Additional studies looking at PD2i as a continuous, real-time marker of clinical status in intensive care patients are currently underway in several countries. PD2i can identify which patients are at elevated risk of anesthesia-related complications, as in this study of women in labor who received spinal anesthesia with sensitivity, specificity, positive predictive value, and negative predictive value, all 100%. Lastly, in the MUSIC trial, a multi-center international study of congestive heart failure patients, a minimum PD2i less than 1.4 was predictive of total mortality and cardiac mortality. So what does this mean to you, the doctor? Better care for your patients. If you had a reliable tool to effectively assess a trauma patient in less than 2 minutes and learn whether the patient requires immediate treatment or could wait, you could minimize triage errors and provide the right level of care to the right patients. You could provide better care and conserve resources. You could be a better doctor. You could save lives.